This talk will not be so technical as ours, but it will highlight the importance of SDC and questionnaires in the real world and the impact they can make. And the impact is tremendous. First, a little bit about me. As mentioned, I'm an international FHIR consultant. I used to work at Philips Healthcare, which is where I did this project. I have just about 10 years of FHIR experience and implementations across the world, both modeling and software development. And Philips Healthcare, who was tapped by ICHOM, a nonprofit organization responsible for patient-centered outcomes, is a division of Philips that specializes in healthcare information technology solutions. They develop software and systems that help hospitals and healthcare providers manage patient data, streamline workflows, and improve clinical decision-making. So it is at this part of unit that I did this work. Now, next is ICHOM. ICHOM stands for the International Consortium of Health Outcomes Measurement, and it is Boston-based, but globally focused independent nonprofit. Now, their main focus is developing standardized patient-centered outcome measures with a focus on clinical and quality of life outcomes. Why do they do this? One of the reasons, as we all know, if you have attended Dev Days recently, or if you've been around healthcare long enough, is that we have a lot of waste in healthcare. There's this famous 30, 60, 30, 10 rule. And as a result of that, about 30% of healthcare investment and funding gets wasted, which is about $7 trillion, which is a lot. So how can we work to reduce this wastage? One of the facts, besides a lot of money is wasted, and besides the fact that investing a lot of money into healthcare does not mean better outcomes, is the fact that certain institutions perform better than others. Patients, if they attend a certain hospital, will have a better chance of being treated right, of coming out with less issues than they are from another hospital or institution. But it's fact. So what can we do about this fact? Well, we can actually empirically measure these institutions, these two institutions and any other institutions, benchmark them across many different variables, and see in which areas are patients better performing. And then we can see which institutions are doing better, and then we can actually look at what is it these institutions are doing better to ensure better outcomes, right? It doesn't really matter what the institution is doing as long as the patients have better outcomes. As long as we can empirically measure that, we can work out what we need to improve ourselves. This is where ICHOM comes in. There is a lot of patient-centered outcomes that we can measure. For example, and unfortunately, mortality rates, readmission rates, things like health-related quality of life, or time to recovery, overall satisfaction, and adverse effects. And of course, different institutions will be placed in different scales here. So what we do is we receive the outcomes data from these institutions. We can analyze the variation. We can then identify what are the best practices that these institutions are following that we can extract and adapt for other institutions. So ICHOM's mission is to define data sets for all of the diseases available that can help us empirically measure and figure out how well is the institution doing. Is it doing great? Is it a leader that should be followed? Or could it use improvement in their practices from the leaders that are on the field? Now, ICHOM has just about 46 sets, different diseases, covering about 60% of global disease burden. That's a lot. I'm not going to go through them all, but this little video should give you an idea. They defined a lot of them. Now, we worked with a sample set called the breast cancer. And let me walk you through a sample set and show you what is it about. The set that ICHOM publishes looks like this. It's a giant Excel spreadsheet. At first, you have a category. So you have things like demographic factors. You have the baseline clinical factors. You have baseline tumor factors. These all factors get measured at the baseline, right at the beginning of the treatment. Then we have treatment variables. When the treatment has started, we measure certain things. Finally, we have disability of care. That's an interesting one. I'll get to that. And we also have a degree of health. Now, this set is variable-oriented, which means that here's a variable ID. For example, last name, sex, year of birth, country. In clinical factors, we have some questions from a questionnaire, and so on. And the variable has a definition. What's it about? There is also a supporting definition going into more detail. Finally, there's a displayed value, which is what will actually be shown to whoever is filling out this questionnaire. We also have an inclusion criteria, either all patients, or I'll get to this in a little bit. And we also have timing. When should this variable be asked? Should it be asked at all times? Should it be asked at baseline only? Should it be asked at baseline in 5 years? Or updated at least annually? Or every 6 months and then 1 year post-treatment? Or updated every 6 months? Or baseline 6 months, 1 year? You can sort of see how the complexity of this is starting to grow, right? Besides the timing source, we also have a reporting source. Who's filling this out? Is it the patient? Is it the patient or the clinical staff? Or is it just the clinical staff? And then finally, we have sort of some metadata such as the typing of this variable, things like response options, not really metadata, this is part of the actual question. And these are sort of like lists. So for a sex variable, we can say male, female, other, undisclosed. For a question that says, have you been told by a doctor that you have any of the following, i.e. diseases? There's a set of diseases you can choose from. Now, what's also interesting is this inclusion criteria. Looking at the previous question, do you have any of these diseases? We see that the following questions, such as, do you receive treatment for heart disease, and does heart disease limit your activities, have a conditional enable one. So that is, this question should only show up if you said to the previous question that, yes, I have heart disease. Same for blood pressure. This question should show up only if you actually mark that you have blood pressure. So this data set that they publish is kind of clever in a way. Besides this cleverness, another important factor to note is the timing. Every variable can be specified at different times. And also just about the amount of variables there are in a single set. You see I'm already up to row 90. We have interesting things like the utility of care. Sometimes the care was worse than the disease, and the impact was much negative. That's plausible. We need to measure this. We also have things like degree of health. And actually, the next 100 variables are just about the degree of health. They're asking the patient, do you have to stay in bed all the time? Do you have pain? Do you worry? Do you feel irritable? Even things like, has medical treatment caused you financial difficulties? If the treatment cured you, you can't afford your basic living now. Was it really good? So scrolling all the way down, you see that there's just about 206 different variables with different timing points, with different sources, and with different conditions. As you can imagine, this is not trivial to implement. And that's some of the feedback that ICHOM has received. So ICHOM has, as I mentioned, they have received feedback, but this is actually a significant implementation effort. Some healthcare providers have managed to implement 3 or 4 different sets. That's up to 600 or 800 different variables, but we found it difficult to scale. And remember, I mentioned there's up to 46 disease sets, covering about 60% of the global disease burden. Imagine how many sets there will be when we cover 100% of the global disease burden. So the scalability of this was really, really challenging. This is where we came in. We created something called IT-ready sets. ICHOM has a strategy of taking the sets and making them more friendly to implementers. Just like FHIR has a strategy of being implementer first, which is why it's receiving a lot of success. ICHOM wants to tap into that strategy. As part of this work, first of all, they mapped a lot of their terminologies to standard LINQ and SNOME codes, which helped a lot. And then they tapped us to create our implementation guide. That's what we did. So let's look at the first. Profiles. In our implementation guide here, we have a nice SVG, which is interactive. You can see the demographic factors. Most of the demographic factors have been modeled in the breast cancer patient profile, as well as the menopausal status. If we look at the breast cancer patient profile, we see that it's quite standard. There's an education level, ethnicity, race, fields for identifiers. What was important that we did here is we created mappings. Since we're mapping from an existing data model, as we've shown, within each profile, we listed mappings from FHIR to the variables in the iCHEM dataset. We also listed them both ways. So going from all of the iCHEM variables, so that this variable is represented in this particular FHIR profile. A lot of them are in the patient profile, but you see clinical factors started going into observations and conditions. Similar factors went into specialized observations. And we made sure to align the work that we did with M-code as well. Now, this is all about profiles, and we're not here on a conference about profiles. So what we also did, very importantly, is FHIR questionnaires of the same data points. And we took the data set and we organized it in a different way, in a way that's more implementer friendly. The previous way we were shown, where it was variable first, was great for clinicians and all of the worldwide experts who were defining these variables. But for an implementer, that was not really a friendly view. So in our work, we split questionnaires up into two types. One which are clinician reported, and others which are patient reported. And then for the patient reported ones, we have just about two questionnaires. Baseline, covers all of these treatment areas, and then follow-up. Finally, for clinician reported, we also have baseline, we have a 6-month follow-up, and then we have an annual update. So we have just about 5 questionnaires that mirror the data in our FHIR profiles. And how these questionnaires work, let's look at the baseline questionnaire. Quite similar to what I've already shown you. Here's things like what is the medical record number, what is your last name, indicate your sex of birth, what ethnicity and race do you identify with. We use standard FHIR values for this, as a means of gender, ethnicity, race. We also, of course, use some dynamic support. For example, a question for menopause should only be enabled when the sex has been answered as female. And of course, also for the question of, have you been told by doctor that you have any of the following? And this corpus of questions that comes to you next, you will not see unless you actually said that you have a previous disease. So here are all of the enablement statements that smartly check the previous question and only come up if the right standard code was chosen. Also in our questionnaires, we made good use of aliases. For example, do you feel you received sufficient information about your treatment options? This is a value set. Do you have any trouble doing things? We generically say yes, no, maybe. This was a value set. And some value sets we were also able to share with questionnaires, with the profiles as well. Now, this is one of the baseline questionnaires that we have. Let me also show you how it looks like in practice in Brian's FHIR lab. Let's get this out of the way. Let's download a sample questionnaire from our profile. So we go to here. So we go to patient reported baseline, download this. Great. Open it up. Copy.
You can copy the URL of that JSON straight into the lab.
Oh.
He says, hoping that it works.
Vadim, you're on mute.
Sorry, I said I trust copy paste more.
Yeah, do that.
So here's our questionnaire, and just as Paul was demoing, this is his questionnaire viewer embedded in Brian's FHIR lab. So you see we have a lot of collaboration going here. And for things like what is your last name, well, we can fill out a value here. That's not very interesting. But what about your sex at birth? Let's say we select female, and then if you noticed, this question was not here before. Actually, if you maybe we select other, it goes away. Like female, it appears. So this is a great example of dynamic behavior. We are the hormone and boss. And then clinical factors. You see there's only one question available for clinical factors, even though there was a host of questions. So what we can actually do is we say, well, I have heart disease. And then automatically the next two questions pop up. Do you receive treatment for it? And does it limit your activities? Well, let's say yes, no. If I select a few more, all of these questions will dynamically show up, which is fantastic. And this functionality doesn't only work in Pulse tool. It works in many others as well. This is where the beauty of SDC and FHIR questionnaires comes in. ICHOM has published these questionnaires in a standard implementation guide, and then anybody can copy paste them, or they trust URL loading URL and load it in, and it will just appear. As you can imagine, for an implementer who previously had to implement 200 of these variables by hand in different applications, screens, or web forms, or whatever else, this is a massive time saver. Doesn't get you all the way to the end, but it's certainly a massive shortcut that I'd love to have with any specification. And just to show you just how well standardized it is, I can also demonstrate to you that same questionnaire that we've seen previously also works in Android. So here's the same questionnaire. I've been told by the doctor, we have any of the following. We select some dynamic questions, and these questions dynamically appear in an Android application, thanks to the folks who put together libraries for this over at Google. It doesn't work only in Android. It also works in LAC forms we showed, but also works in Smart QEdit, which is another questionnaire viewer. Again, standardized. Just by having the questionnaire as data, you're able to load it in and dynamically have a user interface for it, which I think is a superpower that is completely underutilized in healthcare. Probably in other industries too, but in healthcare at least. So if you're part of an organization that is creating any sort of forms, questionnaires, surveys, really do consider distributing them in standardized FHIR questionnaire way. Remember I showed there's up to 46 different data sets. Imagine if ICHOM was able to publish FHIR questionnaires for all 46 of them. At the moment, unfortunately, it's only for one, breast cancer. If you're interested in using it, reach out to them. But imagine how much more adoption would they have if they published this in this standardized way. Everything from mobile applications to desktop applications to web applications would be able to consume their data sets much easier. And the power of questionnaires doesn't stop there as well. I didn't demonstrate this, but other people have today. There's also form pre-population. As you've seen, some of these forms have a lot of data in them. And if the data is already available in EHR, or if data is already available from a previous visit, it would be nice to have the questionnaire be filled in automatically. This is where SDC's capability pre-populate the form based on existing data really shines. And we had a little bit of time left at the end of the project, so we added form pre-population for things like the patient's medical record number, just so you don't have to type the number that you've memorized over and over again to the point where you're getting a little bit sick and you might need care from having to type it over too much. So we can actually fetch it automatically. Perhaps not using this expression though. I should be a little bit cleverer. But also the person's last name. We can automatically fill in the person's last name, the sex they have, and the year they were born, thanks to form pre-population capability of SDC. Besides this, we also have form data extraction. Remember how at the beginning I mentioned that we created profiles for all of these variables, and we also created complementary questionnaires. Well, thanks to form data extraction, we can extract the data from a questionnaire into FHIR resources. FHIR resources are much more workable for applications than questionnaires are. And we can also take these instances and using SQL and FHIR, we can convert this data, these benchmark points, to relational views where standardized charts and BI tools can work with it. And that way we can actually start benchmarking different institutions one against the other. How are they performing this? Thanks to a standardized variables that we ask. And then we can see which patients are receiving the best outcomes in which institutions. And then finally, we can see what is it these institutions are doing to receive these best outcomes and care. We can take these lessons and then we can feed them back into the system to help other institutions catch up. So you can see that this is kind of an empirical and algorithmic way of improving patient care and reducing healthcare waste around the world. Now, at the end of my talk, I would like to make a call to action for two things. One is better support for internalization questionnaire tooling. A lot of questionnaires are going worldwide, and it would be nice not to have to create multiple questionnaires, multiple languages just for the same thing. One questionnaire with many translation should be way more supported by the tooling that we have available. We really need this for worldwide adoption. Another one is what this conference is already doing is, in my opinion, questionnaires and SDC are far, far underutilized. We need far more promotion of all the tooling you guys are building, of the excellent specification that has been built, and all the questionnaires that we can make. Really, let's make more use of it. Thank you. If you'd like to reach out to me for FHIR advice on implementation, here's my email. Otherwise, if you want to reach out to Philips, where I did this work, reach out to Chris Milo. And if you're interested in implementing this set, reach out to Gregor Robinson at IHM. Thank you very much. Are there any questions?
Thank you, Vadim. Any questions from the audience? I see that there are messages from Brian. Brian, would you like to elaborate and contribute?
I just shared the link for brothers if they wanted to try out that form themselves.
Thank you. So I think we are done here. Again, once again, thank you so much, Vadim.